at day 4 of the Congress, the last day. And as a special treat today, I'm here with Dr. Mrinalini Dey, and not here as a EULAR reporter. Welcome, Mrinalini.
Thank you.
Here instead as an academic clinical rheumatology trainee. And we've got a really interesting poster today on the management of acute hot joints. So I've not seen much about acute hot joints here at the Congress. Can you tell me why it's important?
Yes, absolutely. Thank you to EULAR TV for having me here in my day job, what I normally do back in the UK. So yes, acute hot joints are very important to consider in rheumatology. They're a very common clinical presentation to the acute medical setting. Often they're due to crystal arthritis such as gout or pseudo-gout, or non-inflammatory conditions such as osteoarthritis. However, the most important diagnosis to exclude rapidly is septic arthritis, because this can destroy cartilage within days if left untreated. And in fact, the mortality rate in the UK is 7 to 15%, and that's despite antibiotic treatment. So it's very important that we exclude it rapidly when a patient presents in this manner. Now, this involves doing fast arthrocentesis or synovial fluid aspiration, and then sending it off for microscopy, culture and gram stain, and also looking at white cell count. Here in this diagram, actually, we can see from, it's a beautiful diagram from New England Journal of Medicine, just demonstrates the different types of synovial fluid that can come out from various presentations. So we do get different looking synovial fluids in different presentations, but we can't rely on that alone. And so that's the reason it's an important topic.
Yeah, that's really interesting. Thank you. And slightly worrying there. So in this tertiary care centre, how did you go about understanding the diagnosis and management of these hot joints?
Yes, so I'm actually based at Aintree University Hospital in Liverpool in the UK, and we did this work in conjunction with my department in the University of Liverpool, and we were basically looking at laboratory data for a period of 7 months in 2018, just to look at various things. So we wanted to quantify the number of acute hot joint presentations coming into our centre. We wanted to look at clinical outcomes, including mortality and morbidity from our hot joints. We also wanted to look at the clinician diagnosis taken with laboratory diagnosis, and use statistical tests such as sensitivity and specificity in order to analyse and quantify this particular measure. And finally, we wanted to also look at whether measures such as white cell count within the synovial fluid can tell us a bit more and accurately perhaps describe what the diagnosis of the acute hot joint is. Yeah.
So that's very extensive work here. Can you tell me a bit about what you found in terms of these outcomes?
Yes, so we had a total of 137 patients present to our tertiary rheumatology centre over the course of 7 months. 53 of those had a diagnosis of crystal arthritis, and that includes both gout and pseudo-gout. And 10 patients had a diagnosis of septic arthritis. We didn't include in that 10 osteomyelitis or prosthetic joint infections. They were excluded from the 10 that I have. So that's 10 native joint septic arthritis. Now, what we found, first of all, was in the septic arthritis cohort, 80% were culture positive, so 20% were given a diagnosis of septic arthritis on clinician diagnosis. 50% of patients actually had commenced antimicrobials prior to arthrocentesis, and that actually goes against current UK and international guidelines. You should be doing arthrocentesis prior to giving antimicrobials. And also 2 patients did have significant morbidity as a result of their septic arthritis, and crucially those 2 also were part of the group that had antimicrobials administered before their arthrocentesis, so there may be a connection of some sort there. Looking at, if I just draw attention to this graph to you, so this is a graph of mean synovial fluid white cell count for all diagnoses, and it basically shows us very clearly that the white cell count for non-inflammatory conditions is much lower than inflammatory conditions, which in turn is much, much lower than septic arthritis. So as you can see, the septic arthritis white cell count in synovial fluid is extremely high compared to the other diagnoses. Just taking you over to our further analyses, so we performed some receiver operating characteristic curves, or Roc curves as they're commonly called, to look at diagnostic thresholds for septic arthritis and crystal arthritis in white cell count. And these showed us, with an area under the curve of 0.7 in both cases, that the diagnostic threshold for septic arthritis was around 36,000 and crystal arthritis was about 10,000. So again, we see a very clear difference there. So if I may conclude, from all of the results, we basically found that, of course, septic arthritis still has considerable morbidity attached to it. And as I said at the beginning, it's very important to therefore rapidly exclude it and treat it promptly in our acute settings. But also, synovial fluid white cell count may be a good marker of septic arthritis, as can be seen by my graphs and the data that we've analysed, particularly when taken in conjunction with clinician diagnosis. And that actually, I'd like to leave with the thought that perhaps more work is needed in this area to try and find new biomarkers that maybe will be able to exclude septic arthritis to the same level of accuracy as culture. So, yes.
That sounds brilliant. We can only hope. Yeah. So lots to think about there. Thank you so much, Dr. Dey, for joining us and showing us your wonderful poster. I wish you good luck on your poster tour, which is upcoming now.